Hello, everyone. Welcome to today's Neurology Journal Club. I'm Dr. Babak Hooshmand. I'm a senior neurologist pursuing my clinical work in Germany and also a research fellow in dementia prevention field at Aging Research Center at Karolinska Institute in Sweden. I'm joined today by Professor David Smith from the University of Oxford, who I would like to invite to introduce yourself at this point.
Hello, it's very good to join in this discussion. I'm a retired professor of pharmacology in the University of Oxford, and for many years I've been interested in dementia. In 1988, I co-founded the Oxford project to investigate memory and aging, which we call Optima. And this project recruited people with memory problems from the service and at the same time volunteer controls. And we followed them through with scans and blood studies and CSF studies until they died and came to autopsy when we had a diagnosis by the pathologists. So we were able to compare normal aging with the progression of dementia, and in this way we managed to discover a few risk factors for Alzheimer's disease and dementia.
Thanks, David, for joining me. And also we would like to thank the American Academy of Neurology for inviting us to this challenging session. So in today's journal club, we are going to discuss the article recently published in Neurology by Dr. Agarwal and colleagues from the Rush University in Chicago entitled Association of Mediterranean Intervention for Neurodegenerative Delay and Mediterranean Diets with Alzheimer's Disease Pathology. This study concerns an important issue since several reports have shown that around 40% cases of dementia might be potentially attributable to modifiable risk factors. As you can see here, this slide shows the 12 modifiable risk factors identified by the 2020 Lancet Commission on Dementia Prevention, Intervention, and Care that could be targeted to reduce the risk. This list includes several lifestyle and vascular-related risk factors such as hypertension at midlife, obesity at midlife, excessive alcohol consumption, physical inactivity, diabetes mellitus, and smoking, among the other factors. As you can see here, nutrition and dietary components seem to be a missing component of the list, in spite of much evidence. What do you think, David? Do you also believe that the list needs an update to include nutrition and dietary components considering the current evidence?
Yeah, I was very disappointed when I read this report. It's a very thorough study, except for nutrition, which is dealt with in a very casual way and in a very negative way. They give great precedence to the negative results of nutrition studies, and they don't discuss the problems at all. It reflects, I think, quite a common fault that people say if two lots of results don't fit, then the ones that are negative are the ones you believe. But instead of thinking that, I think people should say, why is it negative? What's the reason? Because it might be telling us something. And indeed, in the case of nutrition, that is exactly what it is. It's telling us something. And we'll come on to that later, I think.
Thank you, David. Therefore, we can see how relevant the current paper recently published in Neurology is. But regarding the concept of the MIND diet, MIND stands for the Mediterranean Intervention for Neurodegenerative Delay. This diet is the hybrid of the Mediterranean diet and the DASH diet. The MIND diet was developed by Professor Marta Clara Muris and her group from the Rush University in Chicago, with some modifications to include foods that have been presumably associated with a decreased dementia risk. This diet consists of 10 brain-healthy food groups, such as green leafy vegetables, nuts, berries, beans, whole grains, seafood, poultry, olive oil, and wine, and 5 unhealthy food groups: red meats, butter, cheese, pastries, sweets, and fast food. Therefore, scoring from 0 to 15, and the higher the score, the better the diet is. But the Memory and Aging Project is an ongoing longitudinal study started in 1997 at the Rush University in Chicago, including about 2,000 participants. Dietary assessment started in 2004 by implementing food frequency questionnaires, and around 1,400 individuals completed the food frequency assessments. Of these, about 800 participants deceased, and autopsy data was available in 600 individuals as of June 2021, and these 600 people were target of this current study. Mean age of study participants at baseline was 84 years. The follow-up duration was about 7 years. The study participants were highly educated with a mean duration of education of 15 years, and around 75% were female. At the time of the first dietary assessment through food frequency questionnaire, about 30% of study participants had either MCI, stands for mild cognitive impairment, or dementia. Tangles and amyloid plaque load, which are typical pathologies seen in Alzheimer's disease, were assessed through standardized methods, and a global Alzheimer's disease pathology burden was computed. Moving to the results, basically the authors found strong correlation between the MIND and Mediterranean diet scores, and this is not surprising considering that the MIND diet is basically based on Mediterranean diet to a great extent. The authors found that about 40% of study participants had a clinical diagnosis of dementia at the time of death, and about 66% had a pathologic diagnosis of Alzheimer's disease at autopsies. They found that better MIND and Mediterranean diet scores were related to less global Alzheimer's disease pathology, especially less beta amyloid load at the time of death. The analysis suggested that 1 unit increase in MIND diet score resulted in a difference in amyloid load similar to being about 4.5 years younger. So in simple words, and the better the diet, the younger the brain is with regard to typical Alzheimer's disease pathologies. They didn't find any associations with tangle pathologies, and the results remained the same after excluding people with mild cognitive impairment or dementia at the first dietary assessment. They did some subgroup analysis investigating the impact of different food groups, but they only found an association between higher green leafy vegetable intake, which is a source of folate, vitamin K, and several antioxidants in relation to less global Alzheimer's disease pathology after bone-marrow correction. Of note, the impact of these diets on other pathologies such as vascular pathologies, TDP-43, alpha-synuclein has not been investigated. David, what do you think about these challenging and interesting findings? They are quite novel and really exciting.
I think it's a very important study indeed. Firstly, because it's quantitative and is using standardized assessments of the histopathology, which are agreed by most people in the field. So we have here a quantitative measure in the brain of the influence of these diets, which is much better than just simple measurement of cognitive abilities. There have been several studies on the MIND diet and the Mediterranean diet using cognitive outcomes as the endpoint. And these have been controversial. Some of them have been positive and showed a beneficial effect on cognition, and others have not been positive at all. And so we have this problem. Why is it that some of them are not showing benefit? Part of the reason is the difficulty in measurement in cognitive assessment. The accuracy, of course, of measuring cognition is much less than measuring something biological or pathological. So I think this is a most important paper. It follows from a few earlier papers, one in Australia on beta amyloid load as assessed by brain imaging, and another big study in Germany where they looked at the effect of the Mediterranean diet on markers for Alzheimer's in the cerebrospinal fluid and found a clear effect. They also looked at cognition, and they found that the higher the adherence to the Mediterranean diet, the better the memory. And what was very nice about the German study was that they did brain imaging, and they found that the memory protection or enhancement was related to the size of the medial temporal lobes. Those with a good adherence to the Mediterranean diet had a bigger medial temporal lobe and better memory. So these quantitative studies, like the current paper and those two previous ones, are really important because they give us some hope that something really is happening with these diets.
Thank you, David, for your interesting feedback on study findings and the recent advances in this field. So to sum up the findings of this study, basically adhering to the MIND diet and Mediterranean diet patterns was related to less critical Alzheimer's disease pathology, especially less beta amyloid load. Associations appear to be somewhat stronger for Mediterranean diet than the MIND diet. But the lack of associations with Tanger's was quite surprising. However, it is important to consider that the study did not assess the nutrients status in blood. Therefore, some possible associations might have been missing. Also, it mainly included participants who were older than 80 years of age. So it could be that some relationship would have been present at earlier stages of life. It is important to consider that the mean age of study participants, as mentioned, was 84 years of age, and we know that accumulation of Alzheimer's disease pathologies is a long-term process starting around midlife. So this study is interesting because it shows that diet can still influence dementia pathologies, especially amyloid beta load during later period of life as well. Among dietary components, only a higher intake of green leafy vegetables, a source of folate, vitamin K, and other antioxidants, was associated with less Alzheimer's disease pathology. There was no relationship between fish intake, a source of omega-3 fatty acids, and any of the outcomes except a significant relationship with less amyloid load among men, which did not remain significant after the Bonferroni correction. This could partly be due to the definition of fish intake in the MIND diet. Perhaps this study would have been stronger if it would investigate the impact of these nutrients, such as folate, omega-3 fatty acids, B12, and also other relevant nutrients such as vitamin D or sulfur amino acids such as homocysteine in relation to the outcomes. This is an issue for future studies in case they have plasma samples stores in the Memory and Aging Project at Rush University. David, you are the principal investigator of the VitaCook trial at Oxford, which showed that B vitamins and omega-3 fatty acids slow brain atrophy rate in people with mild cognitive impairment. Would you like to comment on the importance of interaction between different nutrients in relation to structural brain changes, considering the finding of your trial in context of the current study?
Thank you for inviting me to do this. Before I do that, I would just like to say that the components of the Mediterranean diet, not so much the MIND diet, but the Mediterranean diet, which are protective against cognitive decline, have been studied by several groups. In particular, a recent study in 2022 by Dobreva and her colleagues on the UK Biobank. The UK Biobank is a fantastic resource of about 500,000 people who've given blood samples and allowed themselves to be scanned and have cognitive tests over their lifetime. And the end result, many different diagnoses, but dementia is one of them. And this study looked at the Mediterranean diet in the UK Biobank and its relation to dementia, and they found that just two factors in the Mediterranean diet were protective against cognitive decline and the incidence of dementia. One was the consumption of fish, that was a main factor. The other was the intake of fruit. Now, fruit, of course, contains many bioactive substances, but folate is one of them. And in Oxford, we were interested in folate because folate insufficiency, not even deficiency, just low normal folate leads to raised blood levels of homocysteine, the amino acid which is part of the metabolic pathway of methionine. And homocysteine is the known risk factor for many things like stroke and myocardial infarction. And in 1998, Optima in Oxford showed that it was a major risk factor for pathologically confirmed Alzheimer's. So we were curious to see whether giving folate to people with raised homocysteine would actually protect them from cognitive decline. So we set up the VitaCog trial. So the VitaCog trial was designed to study people with mild cognitive impairment living in the community and see whether giving B vitamins to these people, a mixture of folic acid, B12 and B6, over a 2-year period would slow down the rate of brain atrophy, because we'd previously shown that raised homocysteine was associated with an increased rate of brain atrophy, and whether it would also slow cognitive decline in mild cognitive impairment. So they were treated with these 3 B vitamins for 2 years. And we found at the end of the study results which we hadn't predicted, that the high B vitamins status did work, but only in those people in the study who had a good omega-3 fatty acid status at baseline. So you need both B vitamins and omega-3 fatty acids to slow brain atrophy and to slow cognitive decline in people with mild cognitive impairment. I'd just like to show you, because it's such a striking result on the next slide, the effect on whole brain atrophy. This is the atrophy of the whole brain assessed by MRI scans. And what I'm plotting here on the vertical axis is the rate of atrophy per year. And on the horizontal axis, I'm dividing it into 3 groups according to the baseline level of plasma omega-3 fatty acids. Look at the blue bars first. These are the placebo group. You can see that the placebo rate of brain atrophy is about 1 to 1.5% per year, which is typical for people with mild cognitive impairment. If you're normal aging and you don't have cognitive impairment, then your rate of brain atrophy is about 0.5% per year. You can see that the B vitamins shown in red treatment had no effect on brain atrophy in those in the bottom tertile of omega-3, but it reduced brain atrophy by half, 52% in those in the second tertile, and by 68% in those in the third tertile. This was a dramatic effect, really huge effect, as you can see, and it brought the rate of brain atrophy down to the normal range, about 0.5% per year. So this is the result of giving simply B vitamins to people with a good omega-3 status. If you had a drug that would do this, as I presented these results at a big pharmaceutical company, and the head of neuroscience came up to me after and he said, "My God, if we had a drug that did that, it would be worth billions and billions." Well, unfortunately, it's not worth billions because vitamins are very cheap and there's no money to be made from them. But it's nevertheless a very striking effect. The same effect we found on episodic memory and other cognitive measures. The B vitamins only benefited or slowed cognitive decline in those with good omega-3 status. I would just like to show you one last slide. Next slide, please. This shows the regional grey matter atrophy in this trial, in these people. The atrophy is shown in yellow, significant. The yellow indicates the regions of grey matter that show significant atrophy over a 2-year period. And you can see in placebo group that there's quite a bit of atrophy in certain regions, in particular the one marked with the red arrow, which is the medial temporal lobe, which includes the hippocampus, so vital for memory. But you can see that in the B vitamin treated group, there's a dramatic reduction in the amount of regional grey matter atrophy, huge reduction, and that correlates with what I showed you on the previous slide. So these are people who have good omega-3 status and were treated with B vitamins. The effect is, in this particular case, of 86% slowing of regional grey matter atrophy.
Thank you, David, for sharing these really interesting findings, which One part is in line with this current study published in Neurology, shows how important it is to consider objective measures of dementia and cognitive impairment. But moving to strengths and limitation of this study. But some of the strengths of this study include large sample size for an autopsy study, relatively long duration of follow-up of about 7 years. The study was well designed and included annual dietary assessments, and it was novel in investigating the impact of the recently introduced MIND diet on biomarkers of structural brain changes. But regarding the limitations, one was that the impact of other pathologies such as vascular pathologies, alpha-synuclein, TDP 43, and NFL has not been investigated. Food frequency questionnaires was self-administered by each participant, so it could be open to bias. Direct access of different nutrients such as B vitamins, omega-3 fatty acids, and homocysteine, which were mentioned by David, have not been assessed. Also, reverse causality could be another limitation because about 30% of study participants had MCI or dementia at the time of the first food frequency questionnaire, and 40% had clinical dementia at the time of death. There are also concerns with the MIND diet, which, for example, doesn't include fruits other than berries and limits fish. David, your slides from the VitaCook trial clearly showed the impact of several nutrients and interactions between them in relation to structural brain changes in older adults, which suggests considering sensitive objective biomarkers of structural brain changes as an outcome. What would you suggest to be considered as an exposure and as an outcome in future studies and randomized trials on nutrition and dementia?
Well, I think the biomarkers that should be measured in nutritional trials should be designed to measure the status of a particular nutrient. You can measure the nutrient itself, folate or B12, of course, but in the case of the B vitamins, raised homocysteine is an extremely sensitive marker. And the advantage of raised homocysteine is that it's so sensitive that it reveals insufficiency of the vitamins, not just deficiency. And there's a misconception around, I'm afraid, that deficiency is all that matters. And in fact, in the Lancet Commission, they said they didn't recommend treating mild cognitive impairment with B vitamins unless the patients were deficient. But the point is that people with low normal levels of the B vitamins have raised homocysteine, and this is of pathological significance. It leads to increased rate of brain atrophy and cognitive decline. So we must be looking not at deficiency, but at insufficiency. So we need markers that do that. Other markers, which of course I believe in, would be the total plasma omega-3 fatty acids, or if you like, the omega-3 index, which you can do by taking red cells and looking at the ratio of the omega-3s to the other fatty acids in the red cell membrane. That's quite a widely used marker. Other biomarkers would be vitamin C, vitamin D, and some marker of oxidative stress. The markers of oxidative stress are very, very controversial and difficult to define, but certainly if you have one, it should be used, and that will give you further clues about what nutrients are important.
It was really interesting regarding to exposure, but regarding the outcomes, it was your trial clearly shows how important it is to consider, for example, MRI as an outcome compared to merely simple cognitive tests. This study suggests that other biomarkers such as amyloid and tangle pathologies, there are several research going on. The methodology, the sensitivity and specificity is improving every year, and perhaps it would be possible in future to measure them in blood with high reliability for future research in relation to, for example, nutrition. So taken together, this study adds another important piece to the puzzle of nutrition in relation to dementia, cognitive performance, and structural brain changes. And I can say we hope that the upcoming consensus report of the Lancet Commission on Dementia Prevention, Intervention, and Care considers nutrition and its related important components such as insufficient B vitamin status, omega-3 fatty acids, and homocysteine in the updated list of modifiable risk factors, as evidence in this regard is accumulating almost every day. I believe you agree with me on this, David.
Absolutely, I do. I think what's important about these nutritional studies on diet is that diet can be adopted maybe in midlife and go on for many, many, many years. And it's quite a challenging thing to adopt a new diet. But if you can adopt it and it's protective as the Mayan diet, the Mediterranean diet is, then it's very valuable. But diet also tells us something else, the components of the diet which are beneficial, as we've identified, folate, for example, and omega-3s, are substances which can then be targeted in people who have developed mild cognitive impairment. And so that's the second outcome of a trial like this, that it will identify components that can be used to treat and hopefully slow down the cognitive impairment in people who've developed it. So I think this trial is extremely important for many reasons, but those two reasons are at least the ones I think. Thank you.
With that, I would like to thank for your attention and end this session, and thanking American Academy of Neurology for this opportunity to discuss about this paper.